we have uncomplicated system. We are like that it goes through antibiotics, use a lot of water, and give systemic alkalizers. And Kataria will be your best choice because it is cranberry flavored. It is also a 2-day therapy, unlike other systemic alkalizers that you have to use over 5 days. So, as I've talked about dosage, it comes as a pack of 6 sachets, which you're supposed to take as a TDS for 2 days. So one sachet is put in a glass of water, around 200 ml, and it is taken 3 times daily for only 2 days. So that is giving you Kataria form because it's a sachet form. 2 days gives you one complicated society. So we have minimal side effects, and to increase patient compliance, cranberry flavor, and thereby we get high patient compliance with Kataria. So that is the presentation of Kataria. We have samples at our booth, so you can visit for the same. So my next brand is called Lafix, and Lafix is Lonoxicam. It's the first time we are introducing Lonoxicam in the country, first time in Tanzania. Among the Oxyclam class, Lonoxicam is the latest of the Oxycam class, and it has similar pharmacological profile to other Oxycams, but 10 times more potent than piroxicam. It was primarily developed to reduce unwanted effects seen with other NSAIDs, specifically with GI irritations, and it has strong analgesic and anti-inflammatory action because of its potent inhibition of the prostaglandin biosynthesis. So in the WHO 3-step analgesic ladder for pain management, Lafix comes from step 2, where you give less potent opioids plus non-opioids plus analgesic adjuvant. That is in moderate pain, and in step 3, where we have severe pain. And in this kind of pains, the indications in Lonoxicam in chronic pain is in rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, as well as chronic low back pain. So for acute pain, acute sciatica, acute low back pain, dental pain, injury pain, migraine, and which will be more important to you as urological surgeons is in post-operative pain following whichever kind of surgery that you'll be doing. So why we have Lonoxicam is that it is better tolerated alternative or adjuvant to opioids. It's as effective as opioid analgesic morphine, pethidine, and tramadol in relieving post-operative pain following gynecological or other surgeries. And it is very effective for oral surgery. It's as effective as other NSAIDs, sometimes more effective than some, but the key is in its safety profile. So it also readily penetrates perivascular interstitial spaces, including the synovial fluid. So Lafix is most potent balance inhibitor of human COX-1 and COX-2. It has minimal GI side effects, controlled inflammation, rapid onset of action, excellent tolerability, and also has a simple dosing, which is convenient. So as I've said before about the balance, so we strike the balance between safety profile and effectiveness by having minimum inhibition of the COX-1 and optimum inhibition of COX-2. So that is the presentation of Lafix, Lonoxicam. You take 1 to 2 tablets daily, and the daily dose should not exceed 16 milligrams. That is 2 tablets daily. So there is no special modification, dose modification required for the elderly patient unless renal or hepatic function is impaired, in which the case the daily dose should be considered. So my last brand is called Wanda, and this is not new to many of you. So Wanda is the Poxetin 60 milligram. So we say sexual dysfunction occurs when you have a problem that prevents you from wanting or enjoying sexual activity, and it can happen anytime to men and women of all ages. So premature ejaculation is one of the sexual dysfunction, and it occurs when the man ejaculates sooner during sexual intercourse, usually within 1 minute of penetration. So when you're looking about the prevalence, also this is from a while back, the prevalence of erectile disorder, which is most prominent known, and we are getting most of the patients, is similar to premature ejaculation. So this shows that in the community, the prevalence is the same, but we are getting more erectile disorder. but we should be getting similar number of patients with premature ejaculation, but the only challenge is awareness. Most patients are not aware that premature ejaculation is a medical condition and you can get treatment in the hospital. So naproxetine is the first compound developed specifically for the treatment of premature ejaculation between men and women, between men, 18 to 64 years. And it works by inhibiting the serotonin transporter, thereby increasing the serotonin action at the postsynaptic cleft, and as a consequence, promoting ejaculatory delay. So that's just to show how it works. It is able to block the serotonin receptor at the postsynaptic cleft, thereby increasing the duration in which the message is transducted for ejaculation. Thereby, if the patient is ejaculating within 1 minute, we give them a minimum guarantee of 3.5 minutes. So some patients might go to 4 minutes, 8 minutes, or even 10 minutes, but our minimum guarantee is 3.5 minutes. So Wanda comes as a pack of 4 tablets. You take 1 tablet only when sex is anticipated, that is 1 to 3 hours before sexual activity, and you should not exceed more than 1 tablet every 24 hours. But for premature ejaculation, the best approach has been to combine medication with counseling. So therefore, when you get these patients, we highly recommend that you treat them hand in hand with the counseling department. So Wanda, we say we finish together, but some doctors were telling me that you should finish later. So that's all from Kusum. Thank you very much. Have a good afternoon.
We'll have another one from Astra, and then we'll have some 2 or 3 questions from both of them.
Can you just help us?
Good afternoon, doctors. Sorry, the mic was not on. Firstly, thank you to give us the time for a presentation. My name is Kaushik. I'm the country manager for East Africa, Charak Pharma, and our partner for marketing and importation is Astra Pharma, a company which is present not only in Tanzania, but many parts of Africa. To talk about Charak, we are celebrating 75 years research quality trust, and we are based in India. We have very good quality products where quality is assured, WHO GMP approved facilities, ISO certified operations. Our R&D are accredited by the Department of Science and Technology, Government of India, emphasis on product safety, efficacy. Products are trustable, accepted. We are present in many parts of Africa. We are present in Tanzania, Kenya, Uganda, Zambia, Nigeria, Ghana, South Africa. Also, we are present in Europe, we are present in US, we are present in Sri Lanka and many countries of Southeast Asia. That's a global presence. So recent advancements. Herbal medicine is now a modern medicine. Standardized extracts instead of raw herbs. Modern manufacturing techniques and quality control. Scientific validation, standard shelf life and dosage guidelines. To come to our first product of presentation, Adizoa. Introducing a new product. This is specially for a factor where men likes to keep it hidden. So, few terminologies, good sperm formation. You're all aware of these, doctors. I'll not spend much time in it. The three main factors is sperm count, morphology, and mortality. And some important terms where our product deals with: spermatogenesis, which is development of sperm in the testis; oligospermia, reduced sperm count; testospermia, 30% of normal morphology; asthenospermia, 50%; and azospermia. Of course, in this condition, our product will not work. Some important terms is reactive oxygen species. These are very harmful, and reactive oxygen species containing oxygen such as free radicals, which lead to damage to the cells or tissues. Some important another is antioxidant, which is very much necessary. It protects the normal sperm from ROS producing sperm, suppresses premature sperm maturation, and reduce DNA fragmentation. Another important term for our product is sperm hyperactivation. The sperm becomes even more active when they approach an egg cell. They can swim and their tail movements become forceful. You can see a small video which we have attached. Fourth is ALH, amplitude of lateral head displacement, one of the most important parameters used in CASA to assess the sperm's mortality. There also you can see a video which we have tried to show you, posting it there. Another is acrosome reaction, in which is the process by which the sperm is able to penetrate the zona pellucida. Now some factors, doctors, which you are already aware, which is affecting spermatogenesis. Majorly lifestyle changes: smoking, alcohol, marijuana, stress, sedentary lifestyle, and obesity. Drugs, antipsychotic drugs, chemotherapeutic agents, antidepressants, anabolic steroids, antibiotics, tetracyclines, and aminoglycosides. Diseases like cirrhosis of liver, uremia, DM, vernal diseases, prostatitis, tuberculosis, and environmental occupational exposures like pesticides, radiations, etc., which all these leads to effect to spermatogenesis. Functional competence of sperm. The functional competence of sperm is determined by hyperactivation, acrosome reaction, DNA integrity. Goals of our product: for goals of therapy in male infertility. Primary outcome measures: improvement of sperm count, improvement of sperm mortality, improvement of sperm morphology, and the secondary outcome measures are also there: improvement of sperm DNA integrity, improvement of sperm hyperactivation, and achieve chances of fertilization. Coming to our product, Adizoa restores the HPG axis. Adizoa improves the functional activity of LH. Adizoa increases the testosterone level. Adizoa enhances the spermatogenesis and thereby the sperm count. Improves the functional competence of the sperms, sperm mortality, hyperactivation, amplitude of lateral head displacement, acrosome reacted cells, sperm's DNA integrity, antioxidant activity. The most important question, sir: male infertility. Will the sperm be able to reach the ovum successfully? The challenges as given: low sperm count, low morphology, low mortality. So what does Adizoa do? Improves the sperm count, restores in the HPG axis, better improvement in sperm count than clomiphene citrate, ensures morphological improvement, improves the oxidative damages to sperm DNA, superior results as compared to coenzyme Q10, increases mortality, increases the linear progressive total sperm mortality, promotes the hyperactiveness of the sperm. Adizoa in the management of male infertility. We call it the spermatogenius. Adizoa works beyond conventional treatments, enhances spermatogenesis, enhances morphological improvement, increases mortality, and improves functional competence of the sperm, improves the pregnancy success rates. Even the dosages are given as per the sperm count. We would just like to take a second to show you what are the natural ingredients that is present and how much. Asparagus is there, Pseudocardia is there, Mucuna purens is there, and you can see all the rest. Now I would just show the important points to remember for Adizua. Improving sperm count, improving sperm motility, improves sperm morphology, antioxidant property, improves sperm hyperactivation, ALH, acrosome reaction, and improves the DNA integrity. So we say Adizua, the male infertility, which takes care of the total factor. The second product which we would like to go is Vigomax Fort. Vigomax Fort is an product which is already well introduced to you. So it maximizes desires, maximizes performance. So as we say, loss of interest of sex for men over 30, which could be due to stress and hectic lifestyle. Men over 40 could be BP, diabetic, anxiety. This needs to maximize desire and maximize performance. So we present Vigomax Fort, which is already there in the market, increases the libido, reduces the performance-related anxiety, increases testosterone level, reduces bound tolerance for supports, improves the blood circulation to increase intracardiovascular pressure, restores sexual health, promotes strength and stamina, and compatible. Most importantly, this is compatible with all other medicines because this is a herbal product which will not interact with any other medicines you are giving. Again, the composition as shown, the major composition is ashwagandha, kapikachu, gokashur, safed muesli, and the last is erandamula. So benefits: reduces performance related anxiety, restores health and improves overall vitality, improves strength and stamina, improves testosterone level, improves blood circulation to increase intracardiovascular pressure, non-hormonal and absolutely safe, can be given with any other type of medicines. We have also prescriptions from many doctors which has been seen that they have prescribed antihypertensives or hyperglycemics along with this drug. So loss of interest in sex may lead to strained relation. He could be suffering from psychological male sexual dysfunction. So for that, we present Vigomax. So Vigomax for vigor and vitality, trust on Vigomax. The dosage is usually 2 tablets a day for 20 days. Then the doctor has to see the patient's performance. The patient will feel better from the 6th day onwards. So these are the 2 products which we present to you. Thank you for your valuable time and thank you.
Thank you very much, Astra Farmer, for a nice and short presentation. So we'll have comment and question while Dr. Dennis Kanyika is preparing for his presentation.
I have a question. Thanks for that insightful presentation.
Sorry, as we said, before you ask a question, can we please introduce ourselves and then we move on?
Well, my name is Eddie Spesmas or Chacha, that's common name. My question is...
Sorry again to interrupt. From where are we coming from?
Well, US, but now I'm working in Zanzibar with the US Foundation. But I'm Tanzanian, I live here in Dar es Salaam. My question is, how long do you use this medication to see the effects? How long, the time frame? And the second question is, what is the known common side effects of this medication? And the last one, the most common problem here is that you can produce semen which have no, I don't know how to phrase it well. You can ejaculate, but there is no semen there. You cannot fertilize the egg. So does this cure the problem, or it's just a supplement to enhance if you have semen, then you can propagate? That's my question.
So the first question, as you asked, is, I believe you were talking about Adizoa, sir. So how long or what would be the number of days for the therapy? So if you have seen, I have shown in the presentation that if the sperm count is below 5,000, then 5 million, then it is to be given 2 tablets BD for 90 days. If it is above 10 million, then it is 1 tablet BD 90 days. That is the recommendation from us. Could you repeat your second question once again? Because
my second question was, what the common side effects?
Yeah, okay, understood, sir. Sir, as I have shown you the combination, these are all herbal extracts. So, till now, there is no recorded side effects because these herbal extracts are also every day what we are taking in our daily meals. But as a company, this has been refined, this has gone done under a lot of research and come out of the product. And your last question, sir, once again.
My last question was, does it cure that problem you mentioned? I forgot its name, but you can ejaculate, but those semen are very low or nothing at all.
Nothing at all.
So does it cure the problem? Or
No, sir. I mentioned in my presentation, if it is the last condition where there is no semen, this thing, then this will not work. This will only work when the sperm count is low. So if there is no sperm count, the last terminology is when I was showing the product does not work, which I mentioned also, sir.
Last question. Are you...
Sorry, I said sorry. I think they are available outside. You can ask because of time.
Excuse me. Just one question for both presenters. Can we know the cost, please?
The product is available at Astra Pharma at 12,000 shillings per bottle. That is the price from Astra Pharma if anyone goes. But if it goes to the market, some other pharmacy buys and sells, then I think it will be ranging about in somewhere about 17,000-18,000.
The pack of 100 tablets. And the other product, Vigomax, which we presented, is containing 20 tablets for libido. It is costing 8,000 shilling, pack of 20.
Good evening, everyone. My name is Dr. Dennis Kanyika, a resident from Wimbili University of Health in Alexandria. I would like to present my research, my study, titled Erectile Function and Associated Factors among Kidney Transplant Recipients Men Before and After Transplantation at Wimbili National Hospital. And this is a cross-sectional study. So we have displayed also the supervisor and co-supervisor. So to begin with the definition exactly with erectile dysfunction, this refers to the inability to achieve or maintain an erection sufficient for satisfactory sexual performance. This is the definition provided by the National Institute of Health Conference consensus of 1993. This condition is frequently underestimated in kidney transplant recipient men. Usually it begins in the early stage of the kidney chronic kidney disease and it becomes severe as renal function declines. Factors associated with it include long-term effect of uremia, the presence of other comorbidities like diabetes mellitus and hypertension, dyslipidemia, disturbances in hormonal levels, damage to the autonomic nervous system, vascular disorders, adverse effects of the drug itself used to treat the comorbidities, and psychosocial influences. So although the transplantation improved the overall quality of life and survival among this cohort of patients with end-stage renal disease, its role in improving specifically erectile function is still controversial globally. To start with the problem statement, we know as the renal function declines, the severity of erectile dysfunction increase. So as this is a prevalent condition in both CKD patient and kidney transplant recipient patients. It is frequently underdiagnosed due to patient stigma to disclose their diminished erectile function. And also in clinical settings during routine clinical visit, there is no validated tool to routine assess this condition. Factors associated with erectile dysfunction are not yet also identified, especially in our settings, and no study has been conducted in Tanzania trying to assess this erectile function and even associated factors among kidney transplant men before and after transplantation. So, as we know, rationale of this study is due to devastating condition of the erectile dysfunction among this cohort. And in order to allow early implementation of appropriate intervention in kidney transplant recipient, as we have discussed, all those first line, second line, and third line treatment, it is important to identify the magnitude, severity, and factors associated with the worsening or improving of this condition. So we have a reliable diagnostic tool, International Index of Erectile Function with 5 questions. Is important in properly identifying individuals with erectile dysfunction among these patients. Following successful kidney transplantation, efforts to improve the sexual health of this patient desired to warrant the benefits of the overall improvement of quality of life for the affected transplant patients, and this will be important for mutual satisfaction of the patients and their partners. So these study objectives are, to begin with, a broad one, is to assess the erectile function and associated factors among male kidney transplant recipients before and at least 6 months after transplantation at Muhimbili National Hospital. And specific objective number 1 was to determine the prevalence of erectile function dysfunction among male kidney transplant recipients before and at least 6 months after transplantation. Number 2 is to determine severity of erectile dysfunction among kidney transplant recipients before and 6 months after transplantation. And number 3 is to explore the associated factors of erectile dysfunction, of erectile function among male kidney transplant recipients at Muhimbili National Hospital. So the summary of methodology, to begin with the study design, this was a prospective hospital-based cross-sectional study conducted from January 2024 and May 24. It comprised both descriptive and analytical parts due to exploration of the associated factors. Study area is Muhimbili National Hospital Renal Transplant Clinic. Study population are all men with end-stage renal disease who underwent renal transplant at least 6 months of kidney transplantation. The sample size was 67 male kidney transplant recipient, and sampling technique was consecutive sampling. Data collection tool include 2 tools inside the structured questionnaire. These are International Index of Erectile Function 5 question with 5 questions for erectile function assessment, and we employed also patient health questionnaire with 9 questions tool for assessing depression is one of the independent variables. So the data analysis, we used SPSS version 25. We employed ordinal logistic regression using a generalized estimating question G technique to analyze factors associated with erectile function among kidney transplant recipient study. And those with p-value in bivariate analysis of less than 0.2 were sufficient entry to the multivariate analysis. P-value of 0.05 was regarded as statistically significant in multivariate analysis. So these are the inclusion criteria and exclusion criteria. So to go straight to the results, use time factor. This study analyzes a total of 67 adult male patients. According to the nature of the study, all were male. The mean age of the study participants was 46.8 years, with a standard deviation of 11 years, ranging from 30 to 75 to 72 years. On enrollment, the youngest age group is identified in the table number 1, comprises of one patient, and the oldest is above 60, which comprises 20 patients, account for 29. This is on enrollment, and at transplant, these are the figures.
we'll have the rest of the presentation, and then you can jot down your question and we'll ask them at the end. So may we please have Dr. Macha, Dr. Sobo, and Nzoa. We'll start with Dr. Macha, but the rest can come close so that it will save our time a bit.
Good evening, everyone. So I'm Dr. Frederick Macha, postgraduate year 2, semester 4 at MOAS, and I'll be here to present to you a rare case of duplex urethra, which was managed at MNH in January and published, and a case report was developed and published on May this year. So it was a case report of a 13 years old boy who had F1 type 2, A2 urethral duplication. So to give you an introduction, this is a rare situation, is a rare congenital anomaly characterized by 2 urethral channels whose location and extension presents invariation. So urethral duplication has a male predilection, but it rarely occurs in female, and when it occurs in female, it's presented as the 3rd type of F-man classification, whereby you have it presents with 2 urethras and 2 urinary bladders. So the F-man classification is the most acceptable system of classification, which is based on detailed radiological anatomy using the retrograde program. So according to F-man classification, there are 2 main types: the incomplete and the complete type. Whereby the incomplete type is the type 1, which is further subdivided into type 1A and 1B, and as it can be seen from the diagram. And the complete type is the type 2, which has 4 variations. And there is also the 3rd type, which also falls into the complete type, which is type 3, which presents with 2 urinary bladders and 2 urethras. So our patient presented with a chief complaint of an abnormal pinhole opening on the dorsum of the penis for 6 years. And furthermore, the boy and the guardian, who was a biological mother, reported that the boy noticed a pinhole opening at the dorsum of the penis, which was occasionally dripping urine. And this pinhole was noticed 7 years ago after undergoing circumcision. So his guardians and the boy hoped it to close spontaneously with time, but over the past 2 years, there have been recurrent episodes of urinary tract infection, which made them seek for medical care. So on review of other systems and past medical history, there was nothing eventful. And on examination, he had circumcised the phallus with a normal glans penis, normal urethral meatus, with a pinkish pinhole at the dorsum of the penis located at the carina, at the corona. And on examination of other systems, it was unremarkable. So this is a pictorial presentation. You can see the pinhole accessory urethra at the carina on the dorsum. So investigation which were done included the baseline investigation, which was all were essentially normal. We also did echo ultrasound, which was also normal. Furthermore, we did a retrograde program. Essentially, it was normal, but there was a failure to cannulate the accessory urethral meatus. So contrast could not go in through the accessory urethral meatus. But furthermore, we also did MCUG, whereby during the MCUG also it was essentially normal. There was no the accessory tract could not be delineated, conducting contrast during the voiding phase. So after that, we also did urethral cystoscopy, whereby through the orthotopic urethra, there was a normal external urethral meatus, normal fossa navicularis, normal pendulous urethra, coaptating external urethral meatus, normal verumontanum, non-obstructive prostate, but there was mild mucosal trabeculations, and there were no circulation, no diverticulum, no masses, or no stones that were seen. Both ureteric orifices were visualized. However, on the dorsal accessory urethra, the scope could only advance partially, and because the accessory urethra was tapering, therefore, at approximately the mid shaft of the penile urethra, penile accessory urethra, the scope could not advance further. So after those investigations, the patient was prepared for elective surgical excision of the dorsal accessory urethra, and the surgery was performed by a team of urology surgeons, which was led by an experienced urological surgeon from overseas. So intraoperatively, this is how it was approached. So an 8 French urethral catheter was inserted through the orthotopic urethral meatus and advanced it to the urinary bladder lumen, whereby it was ballooned. And a 5 French feeding tube was inserted through the accessory urethral meatus, and the tourniquet was applied at the base of the phallus. So after that, a dorsal midline longitudinal incision was made through the skin and the dartos fascia and the tunica albuginea to expose the underlying accessory urethra channels with the catheter still in situ so as to help in identification. So the accessory urethra was dissected from the dorsum of the penile shaft to provide, to the proximal end where it joins the orthotopic urethra, and it was transfixed and divided proximally. So you can see from the image there where the accessory urethra is being excised and up to the root of the penis where it was joining the orthotopic urethra. So at the site of the dorsal accessory urethra in the dorsum of the penis shaft, which was closed by the 6-0 polybiaxial stitches and followed by the layerly closure of the penile layers by the PDS Maxon 3-0. So 18 French Foley catheter was left in pyorethra for 2 days, and after 2 days it was removed and the boy was discharged. So this was the excised urethra, whereby the histology was done and the lumen was seen to be lined by the squamous epithelium, and beneath it there was aligning lymphoid cells. So after discharging the boy, after 3 months, the boy was followed up again, and this was the image that was obtained. So on checking further history, the boy reported to be passing urine without difficulties, and also reported normal erections without pain and no penile curvature. On examination, the penis was well healed with no pody and no induration was palpable during palpation. So to conclude, the treatment of the urethral duplication should be individualized according to its type, and excision of the dorsal accessory urethra is usually curative in simple urethral duplication, provided that the ventral orthotopic urethra is normal. Though investigation before surgery is mandatory, a thorough investigation before surgery is mandatory in order to determine the nature of the urethral duplication. And the most common diagnostic procedures for urethral duplication include cystoscopy, urethral cystoscopy, the KUB ultrasound, and the micturition cystography. These procedures can help surgeons to plan surgery and prevent complications such as neurovascular bundle injuries and urine incontinence. Surgical excision can improve symptoms, patient self-esteem, and the quality of life. So to wind up, a written informed consent was obtained from the patient for publication of this work. The ethical approval was also obtained from the institution. No funding were involved in this case report. So I'd like to thank my grantor, who was Professor Mkonyi, and Dr. Gabriel Mtaturu. There is no conflict of interest in this particular case. Thank you.
Thank you, Dr. Macha. So we'll have the rest of the two. That is Dr. Salim Sobo, and then we'll finish with Dr. Boniface Nzoa.
Good afternoon. I'm Dr. Salim Sobo, resident from MUAS, year 3. We have a case report with a literature review on successfully reconstruction of the remnants of oral bodies and penile urethra after total glands penis amputation following surgical circumcision in a 5-year-old boy. Case report, we published this case report in November last year and came out in this year, February, so through the International Journal of Surgery case report. Circumcision is the most common surgical procedure done in sub-Saharan countries. It has complications just like any other operation, can be minor or extremely serious. In Tanzania, circumcision is considered a customary ritual and is often carried out by traditional health agents or in an experienced nurses in peripheral health centers. The higher patients to doctors ratio, as well as the level of education in population, likely contribute to this situation. So the Medical Council of Tanganyika, which serves as a legislative authority to oversee the safe and effective practices of physicians and dentists in Tanzania, and prohibits the practice of any unqualified health personnel in the patient care. So penile amputation at any level is rare, but it is one of the most serious complications of circumcision. The management of penile glands amputation depends on the duration before presentation, with an auto transplantation being the desirable management of acute phase of presentation. So for in our case, however, the patient presented to us 12 months after surgical circumcision, in which a penile exploration and phallus reconstruction and neatroplasty was done. So we can see here, whenever there is a glandsectomy as a complication of post circumcision, it is advisable within 8 hours to do intervention. The intervention that is needed is to do autotransplantation. So if you're in a peripheral center where there is no specialized medical personnel, what you're supposed to do is to soak a gauze on saline, normal saline, then apply ice, then transfer both the patient with the amputated glands to the tertiary hospital where they can do autotransplantation. So we're going to see here what was the mistake with that. So it's a 5-year-old male patient from residing at Kigamboni in Dar es Salaam, referred from Kigamboni District Hospital. What happened? This patient presented with abnormal passage of urine for 1 year. The patient was well until 1 year prior to admission when he underwent circumcision done at his house by a clinician from a peripheral hospital. 3 weeks later, after circumcision, the patient experienced severe dull pain, penile pain of a gradual onset, increasing on intensity with time. The pain was later accompanied by swelling of the penis. Revision of circumcision was done again at his house, which did not lead into any improvement. Ever since then, the patient had been passing urine through a pinhole of the stump of penis with normal voiding pattern and denies history of blood in urine, fevers, nausea, and vomiting. Moreover, the informant, the biological mother, noticed there was a reducible swelling at the right ingunoscrotal region area experienced when the patient is excessive crying and during heavy exercise. This is a picture of prior surgery. Picture A shows on the blue arrow shows a buried phallus covered by scrotal skin with total glandsectomy, while picture B shows the scrotal inguinal hernia, right scrotal inguinal hernia with abdominal contents. So the review of other system was uneventful. Past medical and family social was asked by HPI. On physical examination, the patient, there was a normal abdominal contour, symmetrical moves with respiration. Umbilicus was innervated and central located. no organomegaly, bowel sound head. Genital examination, the amputated glans penis, obliterated pinhole, meato opening at the penile stump, well-developed scrotal skin with palpable testes on each hemiscrotal sac, and a palpable reducible mass at the right inguinal scrotal region with soft consistency and non-tender. So on the blood workouts, we did the baseline investigation, full blood picture, renal function, every parameter was normal. We did echo and ECG were normal, so we optimized the patient for penile exploration. So in 12 findings, there was a total penile glans amputation, bara diffalus, significant skin deficiency, and extensive corporal fibrosis extending proximally to the root of the penis. So what was done were penile exploration started by degloving the remnants of fibrotic phallus to the root of penis. Scrotal skin was mobilized away from the distal phallus with significant penile stump of about 5 centimeters. A successful reconstruction of the corporal bodies and the penile urethra was achieved. And this is a pictorial presentation intraoperatively. As you can see, skin deficiency with a mobilization of those remnants. So the ROC shows a degloved phallus stump with assembled corporal bodies with significant skin deficiency. So partial thickness graft of the phallus stump was done from the harvested partial thickness graft from the left superior medial thigh. The skin was mesh defenestrated and placed on the phallus, and the donor site was covered by povidone gels. The patient received antibiotics for 10 days as per institution guideline, and a week later, the graft wound was exposed to heal to reveal a graft takeoff about 90%. Catheter was removed after 21 days, and the post-operative cause was uneventful. A 6-month follow-up of this patient had adequate penile stump length of about 5 centimeters, which was achieved. His parents reported a normal voiding pattern. Normal morning erections were noted by the informant biological mother, and the examination revealed no meatostenosis. So this was the picture D shows phallus stump grafted with fenestrated skin, the partial skin thickness graft, and picture E shows the phallus stump grafted, as you can see there. So the discussion, as surgical procedure, circumcision needs to be performed by qualified personnel in a safe environment. Among the most serious complications of circumcision is amputation of the glans penis. Amputation of glans penis is technical error that ought not to occur. As in our case, it can be ascribed to untrained medical personnel, and the cause of treatment of penile glans amputation is contingent upon duration, as I said earlier. Probably the clinician was not aware of what he was doing, so he was untrained, and also after making the mistake, he didn't know what to do next. So he delayed. He did exploration 3 weeks later. For delayment management, in our case, penile exploration is performed to access the length of the phallus and perform meatoplasty for attaining good voiding pattern and sexual function later on at puberty. However, erythromeatostenosis is most common postoperative complication, and this may require dilatation and revision. Based on clinical presentation, the goal of our management for our patient was to achieve a largely patent urethra opening in the long term and to prevent erythromeatostenosis, as well as achieving adequate stump of the phallus for sexual function later on at puberty. So the need for skin graft depends on the glans abnormality. As for our case, he had a severe skin deficiency and enough scrotal skin. So when it comes to the graft survival in young boys, inner thigh grafting is preferable to scrotal flaps before ensuring the graft's vascular network growth within 5 days of growing NM mechanical barrier. In addition, the amount of wound contraction at the wound bed with little demo inclusion may depend on the kind and the quantity of dermis. Partial thickness skin grafting was achieved to cover the phallus stump and for cosmetic reasons. So psychological therapy. Psychotherapy to the patients himself and the parents, the guardians, was provided as an emotion support, and we think that this need to be also in the sexual function after puberty, so we're still following up the patient. In order to establish high quality standard practice for both the traditional and medical circumciser, such as wearing sterile gloves, using sterile instruments, and providing appropriate aftercare, and to establish formal framework for overseeing and regulating circumcision procedure that should be implemented. Additionally, traditional circumcisers should receive surgical education in order to prevent complications that could be challenging to the handle in the future. The amputation of glands is a serious complication in circumcision because it can derange the urinary and sexual function of the patient if neglected. However, total glandsectomy may result in a short penal stamp. Prevention of penal amputation can be prevented by providing proper training to the unskilled circumcisers and raising general awareness for hospital circumcision campaign, especially for the peripherals. Having said so, thank you, and take-home message here, we could see the management was not proper. It was done first at the environment which is at home with on untrained medical personnel. Moreover, after the mistake, he didn't know where to do, what to do, at what time. So delayed acute phase of management of glandsectomy, and we all know that is autotransplantation could be done. Just here at Kigamboni, we could transfer the patient and the glans penis together so that we could do autotransplantation at Muhimbili National Hospital. Thank you so much.
Thank you, Dr. Sobo. So Dr. Nzoa will finish up, and when you finish up, please, all the presenters should come forward to respond to the questions if they will be there.
Good evening, everyone. I'm Dr. Boniface Nzoa, a urology resident at MUAS. I'm excited to present before the members of this conference on the case report of the patient who was managed at Muhimbili National Hospital. This is the case of an advanced prostate cancer with brain metastasis, which presented with an isolated severe headache without any other symptoms in a classical history of prostate cancer. So even though the prostate cancer is one of the most common malignancies in men, metastasis to the brain is quite rare. And it is only reported in postmortems and literature limited to case reports. The most common sites of prostate cancer metastasis are liver, lungs, and the bones. So this is, in this case report, it's one of the bizarre presentations of prostate cancer. And a prostate cancer going straight to the brain from the prostate, skipping all the common metastasis points, is quite rare phenomenon. And it is only explained through theories, which are, some of them are spread through a paravertebral venous plexuses, straight from the prostate to the brain. In this case, which I'm going to present shortly, not even the skull bones were involved. And the other is, these are just theories, an emboline which passing through a foramen ovary, going straight to the brain, skipping the lungs. So in this case, it poses difficulty in making a diagnosis, bringing confusion to the doctors, and poses more extra diagnostic cost. So on behalf of the other authors in this case report, would like to take you through a case of a 67 years old male man with a history of severe headache, a period of 3 months. Sudden onset, generalized headache throbbing in nature, progressive with intermittent history of dizziness. And this complaint was preceded by eye pain, which the patient visited multiple healthcare facilities without relief of his symptoms. So this patient was then referred to a neurosurgeon who, through MRI, discovered brain lesions and said that these lesions were metastatic. So nothing was done until when we find the primary lesion. So as I presented earlier, this patient had no any symptoms. The review of other systems was uneventful, and even the examination, from the general examination to the systemic examination, even the DRE could not provide any clue to what was happening to the severe headache, and based on the fact that the neurosurgeon said this is something metastatic. So this is the MRI from which the neurosurgeon said this lesion is metastatic and we should work further to find the primary. So went back to find what would be the primary. From the tumor markers to the common lab investigations, we could explain the primary lesions both urologically and from the lab work, and also from the chest to see if there are any primary chest lesions, be it primary or metastatic, whether they are microscopic. So we did a couple of tests to figure out from the lab and also bronchoscopy, but we couldn't explain. And as you can see, the chest CT was quite normal, as beautiful as you can see it. It was until when we did the abdominal pelvic MRI, that's when we got into track and tried to explain what could account for the severe headache. As you can see from the first image, there are some features of prostate cancer. As you can see on the white arrow with extra capsular extension of the tumor. And on the second image, you can see the involvement of the seminal vesicles. And on the third image, the lymph node. This is the point when we got into track and thought maybe the primary would be the prostate, even though the clinical work could not account for. So the TrueCut biopsy was done, and it was found to be an adenocarcinoma of the prostate with the Gleason score of 4+4. The PSA was 7.8, and with that size of prostate, the density was suggestive of malignancy. So at this particular point, we could be confident to explain that the severe headache and the metastasis from which the neurosurgeon found were could be from the prostate, because we surveyed almost the whole possible metastasis, only to find that only the prostate could account for this. And we finally made the diagnosis of an advanced prostate cancer with metastasis to the brain. And when we went further to see the common sites of metastasis, that's the lumbosacral part of the spine MRI, which shows no common metastatic prostate cancer lesions. As you can see how the bones are so nice displayed. only some degenerative changes which occur in old age. Based on the definitive diagnosis, we counsel the patient and we agreed upon doing the bilateral total ectomy, and after 1 month, the symptoms went away. There was no severe headache anymore. The PSA went down from 7.8 to 0.8, and in a 12 months period, this patient resumed his normal activities, and there was no any symptoms. But unfortunately, we couldn't do the control MRI based on the financial constraints. So this is one of the rare case reports, and we should have an high index of suspicion in making diagnosis. And I would like to thank you, everyone, for listening.
Thank you, Dr. Boniface Nzoa, for a presentation on such a rare kind of metastasis of prostate cancer. So can I invite all the presenters to come forward, and if anyone has a question, we can start and address to the specific presenter.
Discussion, something is missing. These are patients who have erectile dysfunction because of chronic disease. They are transplanted. You expect the metabolic effect get a little bit better. But telling us this patient, the poorer erectile dysfunction. Now, because we know that immunocompromisation can actually bring few of erectile dysfunction. The drugs that are used can make patients poorer. I know you are aware of that, but you didn't discuss. That's why I'm saying I'm reminding you, you didn't discuss. Sylvester. Are you telling us that for sure the metastasis from the prostate, because it's just circumstantial evidence? You had an injectomy done, and the patient recovered. The only evidence would have been probably postmortem, or probably again if you had done a follow-up MRI. I still wonder whether really that was.
Thank you, Professor, for your questions. My name is Dr. Dennis, the first one responsible to answer your question. To respond to your question, Professor, we had the discussion session, and it is clear currently that there are several studies that are aligned with my findings due to the fact that kidney transplant alone cannot eliminate all the comorbidities that predispose or precipitate erectile dysfunction to this cohort due to multifactorial nature of the cause of erectile dysfunction. And apart from restoration of glomerular filtration rate and hormonal disorders, it has been declared that majority of the comorbidities like hypertension and diabetes plus drugs that are used to treat them had no any positive impact with the kidney transplantation. But also, these are the patients. On top of that, they were put on immunosuppressive agents, which in turn has hormonal interruption and worsen the whole mechanism of erectile dysfunction. But these patients also had high level of anxiety and depression, which is the most neuropsychiatric disorders responsible for non-organic or psychogenic erectile dysfunction. And these findings is supported by many studies, one done in Italy with Malavald, who found 88% and 95% of erectile dysfunction post-kidney transplant, respectively. But also, due to high prevalence of erectile dysfunction to this cohort, according to these findings, you can find a majority of the independent factors can be confounded due to the multifactorial natures of the occurrence of the erectile dysfunction toward this cohort of the patients. Thank you, Professor.
Good afternoon, Professor. I'm Dr. Salim Sobo. I'm the one who presented about the case report on the glandsectomy, the complication of circumcision. Yes, concerning the degloving, we planned it for exploration, total exploration, because we didn't have a clear understanding of the anatomy after glandsectomy, and considering the time of the injury, that 1 year ago. So what we were seeing previously was just a pinhole with a buried tissue obliterating the surface. So we didn't know that we had the glands inside or it wasn't outside. So we had to explore
I
everything.
think you got the question wrong. You're talking about the duplicated urethra.
Duplicated urethra. Duplicated urethra.
We're talking about the duplicated urethra, not the amputated.
Can you come again, Chief, for the question?
What I said, don't you think that the better incision would have been a degloving rather than putting an incision on the dorsal?
Thank you, Professor, for your nice question. For me personally, I think degloving, of course, would have been a better incision because it will prevent so many complications such as COD and prevent also the risk for peyronie disease. Also, will have cosmetic results. But I think it was just a surgeon's preference, but I think degloving would have been better.
Thank you, Professor, for the question. As I said, this is a quite rare phenomenon, and it has been explained only in literature reviews, previous cases, and we found similar cases around the globe with more or less similar presentation, and though there are few published cases, and in a case like this, biopsy is not indicated if we suspect metastases from from the prostate. Taking the biopsy into the brain is not indicated, and we had clinical evidence that this patient had a very bad headache for that period of time, which kept on going from multiple centers for treatment, and this headache got better only after ADT, and we did a lot of work to exclude metastasis from other parts.
So thank you. I just want to have a bit of a question to Dr. Sobo, and then I think that will be my last. That will be the last question for all presenters. So I just wanted to know the length of the stump. We said 5 centimeters. Is it a stretched length of that stump, or it's just a flaccid? And then there is a statement to say that the circumcision is done by unqualified nurses and traditional. Is there any study to back up your conclusion, or it's just based on what we see in the street? Thank you. So when you respond to that, I think others can go back.
Thank you, Dr. Mocha. Yes, the stump that was 5 centimeter there, that was on a flaccid. We didn't induce an erection at that moment. So that was after degloving and trying to rearrange the corporal body structures. That is 5 centimeters that we achieved. And on the second question, considering the practice that is done, I have no evidence on the paper like that. The practice that is done and the campaigns that are taking place in most of the highlands there in Lake Victoria, you can see nurses trained, EN nurses are taken for the campaigns. So most of them, they're just doing it as medical personnel, but not well trained. So I believe that if there is a crash program, at least 3 months for those patients, for those medical personnel, this will reduce the rate of complications, especially this one.
So thank you. So I think you need to say it clearly that it's from the observation and not, you don't have any study to back that up. So thank you very much for everyone. Thank you for the presenters. I know it has been a long day, but thank you for everyone who was able to attend and was attentive throughout the presentation.
Maybe, maybe just to add on that, there is a study which was done in Port Harcourt, Nigeria, regarding what he has presented about the circumcision, which was done by traditionals, and they found many complications which were done by the untrained circumcisers. So they had a campaign of raising awareness to hospitals, at least people from the villages, to understand the importance of being circumcised by a doctor. However, to the interior regions of Nigeria, most of the circumcisers, the traditional circumcisers, are the ones who are in charge. So there is only very few limited studies which are backing up about untrained circumcisers to do circumcisions, like that one in Port Harcourt, Nigeria.
Okay, so just some few announcements for tomorrow. So tomorrow we'll start a bit early. So as the timetable shows, it will be from 8, and then 8 to 8:30 will be registration. And please remember, you have to register in 2 separate sheets, one for normal registration and the other one should show the names as you wish them to appear on your certificate. So we have left with 6 presentations from tomorrow, so we will try to arrange so that we'll finish all of them, because people took time to prepare, so we don't want to let them down. And before, I will ask if there's any announcement from the leaders. Dr. Mahenda, is there any announcement? So just 1 minute of your time, throughout the presentation, throughout the meeting, throughout the conference, we are live through Informative TV. So I'll give him just 1 minute, and that will mark the closure of today's conference and we reconvene tomorrow. He will just introduce himself and say his role and where Tausi how can Taus work with him.
Thank you. Thank you so much. My name is Albert Kilala. I'm the Director of Marketing and Communication from Global Medcare and Global Education Link. In our association, we have Informat TV, which is mostly dealing with promoting health, education, and environment. It was short notice yesterday when we requested to be part of this meeting with you, but really we thank you for really accept us be part of this. And through this, I'm sure we're going to open doors to work with you. Informat TV, we always do education free of charge. You know, we have so many media in town here, but most of them, they are commercial. But through Informative TV, I really request the management, Mr. President, Dr. Permanent General Secretary, and all leaders here to accept Informative TV to work with you, really to educate our fellow Tanzanian based on your issues. We have been dealing with the Professor Janabi in cardiac issues. We'll be dealing with the Mloganzila, Muhimbili itself, Moi, but in the very special way. Kindly accept us to deal with you, to inform Tanzania based on your issues. There is so many issues we, who are not doctors, we are facing, and we need education. Through Informat TV, which is online-based TV, we can request to work with us so as we educate our fellow Tanzanians. Thank you so much for accepting us, and we're going to be with you again tomorrow for the last day. And we are very much sure we'll invite you leaders to our office to meet my other directors with my authorities. As I'm saying, it is free. I'm sure 100% all my team will accept this. Thank you so much, and allow me now to spend my time with you. Thank you indeed.